The purpose of my project is to establish interventions for the postpartum population to improve mother-infant relationships, interactions, and the overall well-being of families. Patients are at the highest risk of depression in the first year after the birth of their child. Another goal for the project is to investigate what is needed for appropriate recognition and management of the parental depression for nurse practitioners. Motherhood nowadays is regarded as a life transition period, testing and straining women's coping mechanisms. Prevalence rates range from 5 to 25% depending on the characteristics of the population and the diagnostic and evaluation methods and framework used. Increasing attention has been paid to postpartum depression due to its consequences not only on the mother's functioning, but on the cognitive, behavioral, and emotional development of the infant. My target population would include females 18 to 40 years old that deliver a term infant at least 36 weeks old gestation at the University of Kentucky in Lexington, Kentucky. All women of any racial or socio-economical background would be allowed to participate in this proposal. Exclusive criteria for the proposal would include mothers that are less than 18 years old. Exclusion criteria, mothers that are less than 18 years old or older than 40 years old, mothers that delivered an infant less than 36 weeks gestation, and mothers who deliver a stillborn baby. Anticipated number of participants would be 100. This group was created because recently had a baby about 9 months ago, and I always was nervous about postpartum depression, but I didn't really know a whole lot about it or interventions that were typically used to treat it. Some highlights from the literature review indicated that there were substantial data indicating potential health consequences of untreated postpartum depression on the mother, infant, and family. Many studies have evaluated interpersonal psychotherapy or IPT as a treatment for PPD. The results are questionable due to methodological limitations. Others favor talk therapy as a form of PPD, such as IPT. Unfortunately, IPT is not widely available, especially in rural or remote areas. In order to improve care for PPD, telepsychiatry has been introduced, including therapy over the phone. The last 15 years have seen an increase in the development and availability of family-based interventions for infants at risk for relational disorders and compromised development. Infants of depressed mothers often display more withdrawn behavior, decreased activity level, greater fussiness, and fewer actively positive facial expressions and vocalization, almost mirroring their mothers. Healthcare providers that serve pregnant women, new mothers, and newborns should have routine screening protocols and educational mechanisms for staff training and client education related to postpartum anxiety disorders. Postpartum depression is the most common of pregnancy and affects 1 out of 5 women, which creates a significant problems for nurse practitioners. Postpartum depression is defined as a serious mental health problem characterized by a prolonged period of emotional disturbance occurring at a major life change and increased responsibilities in the care of a newborn infant. My proposed pilot would be to have volunteer participants will be asked to either complete a paper questionnaire included in their discharge paperwork from the hospital, telephone interview, or face-to-face interviews using recorded audio tapes with transcription later conducted by the principal investigator, describing how postpartum has affected themselves, their infant, or family dynamics. Information will be provided via posters, flyers, or questionnaires throughout the postpartum units or discharge paperwork within the hospital setting to promote participation in the study. A planned intervention for postpartum depressed women would be to randomly divide the group of participants into a control and experimental group. Both groups will be evaluated via a telephone or mailing questionnaire at 3, 6, 9, and 12 months postpartum. The experimental group will be allowed to join other mothers for bi-weekly monitored sessions with a professional family therapist for 1 hour intervals, with a control group receiving no therapy sessions. Outcomes will be measured using 3 different methods: the Maternal Mood and Psychological Functioning Depression Scale tool, measuring sleep, eating disturbances, anxiety, insecurity, emotional liability, and mental confusion. The second tool would measure mother-infant interactions, a 42-item mother-infant videotaped interaction, and the third tool would include an Edinburgh postnatal depression scale to assess degree of depression symptoms. Thank you.